Thanks, Cindy, and hey again, everyone. Thanks for sticking with us for another great day. I hope where you are, if it was as gross as it was yesterday here, that you're getting some of the sun that we're finally having. So today we're gonna move a little bit deeper into some STI issues, and I've titled this one STIs 102. We're gonna talk about some somewhat less common pathogens, though still things you're pretty likely to encounter, and try to move into a little bit of the evidence behind why we handle these the way that we do. I have the same disclosures, no financial disclosures, and the PTC disclaimer about aligning with the EOs. So today, we're going to first start out by revisiting the differential diagnosis of non-gonococcal urethritis. You talked about this a little bit yesterday with Dr. New and talked briefly about the workup for that. And then we're going to go into a little bit more depth about Mycoplasma genitalium specifically. We'll talk about presentation and testing. We'll talk about treatment, especially including rationale around why we do what we do and resistance concerns and some options for treatment failure. We're going to move on from there to talking about genital ulcer disease as a broad category before taking a deeper dive into genital herpes. And then finally, at the end, time permitting, we're going to spend a little bit of time on epididymitis and orchitis. All right, so we're going to start out with a case right from the top. This is Jeremy. He's a 35-year-old man who comes into sexual health clinic where he's seen regularly for PrEP. He complains of 5 days of dysuria and some kind of mucopurulent penile discharge, all pretty familiar territory so far. In his sexual history, he does have a history of chlamydia urethritis about 3 months ago. He got treated in an outside clinic with azithromycin. Since then, he's had 5 male and 2 female sex partners, and he reports having condomless anal sex, both receptive and insertive, as well as vaginal and oral sex. On exam, you don't actually see any active discharge while he's with you, but you do see just a bit of trace meatal irritation. You order comprehensive STI and HIV testing, including urine gonorrhea and chlamydia, so that's part of 3-site urine gonorrhea and chlamydia testing. And then you go ahead and prescribe empiric ceftriaxone and doxycycline for him. When the tests come back, you find that the urine gonorrhea chlamydia is negative. And when you call to discuss the results for him, he's about to finish his course of doxycycline and tells you his symptoms really haven't changed. And so at this point, we're going to have our first poll of the day. What further workup would you send? Would we get an RPR with reflex to the FTA antibodies, so our traditional algorithm we talked about yesterday? Would we get an HSV and HSV2 PCR from the urine rather than a swab? Should we just repeat that gonorrhea and chlamydia gnat in the urine? Do we want a urinalysis with microscopy and maybe reflex culture? A trichomonas gnat, a mycoplasma genitalium gnat, a urine bacterial culture, or have we really just reached the end of our rope? We're going to get a PET CT of the whole body and just take a look to see everything that's going on. Jessica's waiting for maybe a few more comments to roll in, but let's go ahead and call it. And we'll circle back to this in a little bit. See most votes for Mycoplasma genitalium gnat, excellent. And I've got a number more for Trichomonas gnat and everything else kind of equal. Only one taker for PET CT of the whole body. Our nuclear medicine colleagues, thank you for the business. But all right, so let's talk once again about non-gonococcal urethritis. You'll recognize this slide from yesterday's talk with Dr. New. And the terminology really comes from a time where gram staining and microscopy at the point of care were more common, and people could really quickly rule out gonorrhea as a cause of urethritis. But in the case of modern practice, where we typically are, given sort of the increased use of combined gnat testing with gonorrhea and chlamydia, is not so much this non-gonococcal urethritis, looking at things under a microscope, but really non-gonococcal, non-chlamydial urethritis. This is what we're really kind of facing when that combined gonorrhea chlamydia gnat comes back negative. And you saw some of the differential for this before, and you can see that Mycoplasma genitalium really leads the way up to a quarter of cases. With Trichomonas vaginalis, kind of a handful of the rest. HSV, a small percent, and then it's really a grab bag of other pathogens and a large section of unknown origin and folks coming in with a really unclear etiology. And so, going from that to thinking about what kind of workup we can send. There are a few things that I usually kind of think about at the top here, all of which I think you all were pretty good at picking out. So one is the Trichomonas urine gnat, particularly in men who have sex with women. For women coming in, for female patients coming in with kind of more urethritis kind of symptoms, Trichomonas actually isn't as much of a consideration if that's what's happening in isolation, if there's no symptom of vaginitis, etc. If that case, if you're suspecting that maybe Trichomonas is to blame here, think about a pelvic exam to try to better delineate what the symptom or what the syndrome actually is. The Mycoplasma genitalium gnat, everyone picked that. But I want to make a point here, and we'll circle back to this a little bit more later. When I say Mycoplasma genitalium, I'm actually specifically not saying also Mycoplasma hominis and Ureaplasma species. Many labs, including our lab here, unfortunately, combine all of these together, and it can often really lead to some confusing results. And so wherever you have the option, Mycoplasma genitalium gnat alone is really the recommended test here. And then you can consider HSV PCR. You saw from that previous slide that that's really only a small percentage of cases, and having urethritis in which other external lesions aren't visible isn't common, though it is possible. And so when you're kind of reaching for kind of what could be the issue here, it is one thing to consider. And finally, I just want to recommend that, when I have someone for whom the first round of workup isn't revealing a cause of urethritis, I really recommend trying to confirm that the patient's sort of self-reported discomfort and other things really are urethral inflammation. One way to do that, of course, is just to see the discharge that they're reporting. And another is to check a specimen of first void urine. And you should really see more than 10 white blood cells on a spun sediment in that first void urine if the person is having ongoing urethritis. If you're not seeing that leak esterase or those white blood cells, then you might want to rethink and consider some other diagnoses, things like chronic prostatitis or chronic pelvic pain syndrome, interstitial cystitis, other entities that cause kind of chronic pain and urethritis-like symptoms. All right, so for our patient, I highlighted a few of the things that you might send here. Any of these can be correct answers, though you might not choose to send all of them at that kind of first follow-up. So in this case, that might be the HSV1, HSV2 PCR. That's kind of a plus minus. The urinalysis with microscopy, ideally. A Trichomonas gnat, since our patient did report having sex with female partners. And then, of course, the Mycoplasma genitalium gnat. All right. Oh, and just to go back, urine bacterial culture, may be a consideration in someone coming in with more typical dysuria, suprapubic tenderness, etc., and especially maybe in older patients, something that you might think about, but not something that I chose to include here because of this patient's age and history. All right. So Jeremy's results on the UA, you do in fact see some pyuria, so there are 20 white blood cells there. The Trichomonas urine gnat is negative, the HSV urine PCR is negative, but that Mycoplasma genitalium gnat is positive. So let's talk a little bit about MGen, the short for Mycoplasma genitalium, and all of its relatives. They belong to this class called the mollicutes. So mollicutes are defined by a lack of a peptidoglycan cell wall, and there are a couple other significant genera, including the ureaplasma that you might have encountered. They're largely parasitic and intracellular, and kind of interestingly are some of the simplest and smallest living things with these really tiny genomes. All those features unfortunately make both testing and treatment really difficult. They're very hard to culture, and so our diagnosis depends on that molecular testing with those NAT tests. And that same simplicity confers some intrinsic resistance to a lot of our preferred antibiotics. Since there's no peptidoglycan cell wall, we can't use the beta-lactams or glycopeptides or things like fosfomycin. Since they don't metabolize their own folic acid, we can't use Bactrim, and the list really goes on. Also of interest, MGen specifically has a little bit different epidemiology than some of the other things that we'll talk about, in which it's relatively prevalent and not always associated with actual disease. So in the 2017-2018 NHANES survey revealed an overall prevalence of about 2% among people in the US aged 14 to 59, so kind of younger adults. Other case series put that prevalence around 5% in the general population, but the numbers go up pretty significantly in STI clinics, so around 26% among women and just a little bit higher among men. There's also a higher prevalence among folks with HIV. Unlike some of the other things we've talked about, that prevalence isn't increased among men who have sex with men. And in that group, interestingly, MGen is typically detected more often in rectal specimens than in urine, and much more than pharyngeal. I'll just point out, and we'll talk about this later, but kind of 3-site testing for MGen really not generally recommended. Also, note for MGen, concordance among couples is actually pretty high, up to 50% in heterosexual couples, and the limited data we have among MSM showing a little bit lower numbers there. All right, syndromes associated with MGen. Since we mentioned that it can be incommensurable, it's really important to think about what kinds of clinical scenarios might be consistent with MGen acting as a true pathogen. Studies that have tried to kind of sort this out have really been challenging just because of the difficulty kind of attributing causality as opposed to just sort of an epidemiologic association. And so I know this slide is a wall of text, but I've tried to be kind of thorough so that you can get a sense of where that information has kind of showed a clear causality and where it hasn't. In men, the most sort of straightforward association that we have is with urethritis. Like we said, we know it causes up to a quarter of that non-gonococcal, non-chlamydial urethritis, and up to 40% of persistent or recurrent urethritis. This is really where we have the best evidence for MGen as a true pathogen. For proctitis, there's a really conflicting association in MSM between rectal MGen detection and symptoms. It's weak or not present. And for pharyngitis, it's really just not there at all. There's also no clear association with chronic complications, things like prostatitis. So in male patients, you're really thinking of MGen as a cause of urethritis primarily, and for other things, I would argue that it's probably not worth putting in your differential most of the time. For female patients, similarly, there's some pretty good evidence for MGen as a cause of cervicitis. So it's detected in 10 to 30% of women with clinical cervicitis. Co-infection here is actually really common. And so sometimes it can be difficult to tease out, is the MGen really driving symptoms versus maybe a more typical pathogen, gonorrhea, chlamydia. But the studies that we have that kind of best suggest some causality show that if you treat the MGen specifically, you do get a normalization of some of these inflammatory cytokines. So we feel pretty comfortable suggesting that MGen can be a true pathogen there sometimes. For PID, the evidence is a little spottier. There are multiple studies that demonstrate greater frequency of MGen in women with PID, but they tend to be kind of cross-sectional. And there's no clear prospective evidence of cause or trial data showing that treatment of MGen cervicitis then prevents subsequent PID. But of the other kind of syndromes that we might think about, we feel relatively confident that MGen is in some fashion at least implicated in PID. There's a lot of talk about MGen as a cause of potential pregnancy and fertility-related complications. That's another place where the data actually gets even murkier. We'll keep that as a separate discussion. Back to our patient, back to Jeremy. And so he has clear symptoms of urethritis. He has a UA that shows us that pyuria, and now a positive NAT. So what is our treatment? Really pulling for some bloodletting. I hope somebody's got some old school tools available to them. But all right, Jessica, let's close it out and see where we're at. Okay, so I suspect that a lot of folks here really do have some experience with MGen because we got a majority picking the doxycycline for 1 week, followed by moxifloxacin for 1 week, and our runner-up is doxycycline followed by azithromycin. And so since you all have a pretty good sense, I think, of what the recommended treatments are, let's take this moment to do a little bit of a deeper dive into why that's what's recommended. Here we go. So we mentioned before that intrinsic resistance in the MGen bacterium leads to reliance on just a couple classes of antibiotics. So these are our ribosomal agents that have a good ability to penetrate into host cells where the bacterium is living. And the main classes we're thinking about here are macrolides, tetracyclines, and quinolones. And we'll talk about those all in turn. I'll just point out at the top here that azithromycin, this 1 gram for 1 dose, used to be the standard for syndromic treatment of non-gonococcal urethritis. And you heard from Dr. New about kind of why the guidelines suggested changing that over to doxycycline. And it used to be the case that that same 1 gram dose of azithromycin had good efficacy against MGen. But we know now that sort of since those initial sets of guidelines came out, we actually have a significant decrease in macrolide susceptibility among isolates of MGen here in the US and abroad. So this study kind of does a global systematic review looking at the rates of microbial cure using azithromycin for MGen. And what they found was this kind of pooled overall rate of 77% over the study period that actually only goes up through 2015. But the most notable finding here, I think, is that it decreased from about 85% in studies that were prior to 2009 to about 67% in the studies that went from 2009 to 2015. And since that time, we know that at least sort of genetic prevalence of macrolide resistance in genitalium isolates has gone up even further. And so this is a collection of different studies kind of from around the US, looking at how, what proportion of MGen isolates had a macrolide resistance gene. And you can see that in most locations, it's over half, if not, as in, for instance, Seattle among MSM, the really vast majority of MGen. All right, so we know that macrolides are no longer as reliable an option as they once were. Let's take a look at quinolones. So this review paper was another kind of global review looking at genetic prevalence of quinolone resistance mutations. And from the 2016 to 2017 period, they were also not insignificant, almost 10%. There's a little bit less data for the Americas region specifically. They put a point prevalence at about 10%, though that kind of came from only a relatively small number of studies. The other notable thing I think you can see here is the overall rise there on that kind of left-hand graph, and the more significant rise that we see in the Western Pacific region, so East Asia, where this is actually a real problem. Okay, so quinolones, still okay, but maybe there's some trouble on the horizon. Let's talk about tetracyclines. So doxycycline was part of the treatment regimens that most of you all picked. But we noticed that it's not really there as a single agent. And in fact, we know that single agent therapy with doxycycline for MGen actually has pretty poor rates of cure. So this study here looked at 263 patients in Norway that were treated with 2 weeks of doxycycline, and only about 59% actually had a negative test of cure following that. It is worth noting that an additional 35% of the symptomatic patients who didn't achieve a microbial cure, so didn't achieve a negative test of cure, actually did have symptom relief or resolution after that 2-week course of doxy. So it's not always the case that you need a negative MAT to get kind of a clinical cure, symptom cure of MGen. It's kind of unclear why this is. Also, there don't seem to be any clear associations between some of the mutations that might confer doxy resistance in that 16S RNA with kind of clinical observed doxy resistance. And that's kind of the part of the basis for actually the advantage of doxycycline and the reason that we still use it. And so this study from 2021 actually did a really interesting thing where they collected a bunch of MGen specimens in France and then passaged them through 30 generations of sub-inhibitory concentrations of doxycycline or tetracycline. So essentially like trying to induce resistance in these bacteria. And actually none of them developed an elevated MIC to doxycycline by the end of that experiment. There were several that had these RNA mutations that are sort of associated with doxy resistance, but they were still in vitro susceptible. So at the end of the day, the drug still did have activity. And this is great because we know that unlike the macrolides and unlike the quinolones, we can use doxycycline without kind of encouraging a whole lot of treatment resistance, even if it doesn't get us to the point of that clinical and microbial cure. And that's how we wound up with this current strategy, this what we call resistance-guided sequential therapy. And this is the paper that sort of proved this practice. I'll start out with kind of one of the earlier charts from this table, where you can see the bacterial load of MGen before and after treatment just with doxycycline for 1 week. And you can see that there's still a significant amount of MGen post-treatment, but that bacterial burden went down by about 3 logs. And so this is really the role of doxycycline here. It's bringing down the quantity of MGen in a symptomatic patient prior to using a second agent whose purpose is really more curative, and ideally kind of decreasing the chances for treatment emergent resistance as you have sort of less bacteria starting out when you're giving that second agent. In this paper, what they were able to do is use resistance-guided therapy, resistance-guided testing to choose that second agent. And when they picked that second agent based on resistance testing, they were able to get success rates of 92 to 95%, really kind of outcompeting any single drug outcome. When in this study, they found macrolide resistance. They used citalfloxacin as their secondary agent, but there was also a follow-up study where moxifloxacin, which we're all a little more familiar with, was used with really similar results. And of course, if they found that the MGen isolate was macrolide susceptible, they used azithromycin after doxycycline, also with excellent results at that time, and a really low treatment rate of treatment-associated macrolide resistance, which is really great. So this strategy of using resistance testing to guide our therapy results in both excellent rates of cure and really low rates of kind of promoting resistance. And that all sounds great. But in practice here in the USA, unfortunately, it's really hard to do. And so molecular tests for macrolide resistance aren't yet cleared by the FDA. This is the example of the test that they used for that study in Australia. But there is increasingly more availability of some lab-developed tests from some commercial labs like LabCorp or ERA that might be available in your area. I'm not promoting either of those, but those are the ones that I know do have that available. There is another option, which is sending specimens out to the University of Alabama at Birmingham, where they do a lot of kind of basic science research on MGen. In addition to macrolide resistance, they are now starting to offer quinolone resistance testing there as well. It's a bit more of a process to get specimens in, but it is an option. All right, so coming back to Jeremy, the majority of you were absolutely right. Here in the US, where we don't have the option to sort of demonstrate macrolide resistance, our default treatment strategy is doxycycline for 1 week, followed by moxifloxacin for a second week. Other options on here, we'll talk about minocycline in just a moment. And this doxycycline followed by azithro is only indicated if you can kind of prove with resistance testing that that isolate is macrolide susceptible. We know that azithromycin for 1 gram times 1 dose is no longer a recommended treatment for NGU and definitely not a treatment targeted for MGen. And the moxifloxacin 400 milligrams for 14 days can actually be part of a regimen for PID where you're looking at MGen, but is not a standard treatment for MGen urethritis. All right, so let's talk about treatment failure. And MGen treatment failure is unfortunately relatively common. There are sadly really few treatment options remaining to us here in the US for this. And so this is a little bit of a scary situation. The best data we have comes for treatments based on minocycline. The paper that kind of demonstrated this showed that there were slightly lower MICs for Mino than for Doxy. And in a couple of case series showed around a 2/3 cure rate with this 100 milligrams twice daily for 14 days. Interestingly, in that case series, about 62 of those 90 patients had previously failed treatment with moxifloxacin specifically. And so we have kind of pretty good generalizability to the population where we might want to use this. There's been a little bit of subsequent data coming out of some of the same groups that looked at this initially that adding metronidazole might confer a little bit better cure rate, not sort of night and day difference, but that's something that's starting to be explored. In other parts of the world, pristinamycin is the next reach for failure with a quinolone. About 75% of patients with macrolide resistant MGen have been cured with that after 10 days worth of treatment, but unfortunately that's not available in the USA. Every now and again, we have a patient who might be traveling somewhere to Europe, for instance, where they can get a hold of this. And for folks with really refractory disease, it might be an option. But for most of us and for most of our patients, this probably isn't going to be a go-to, at least for now. All right, and my last point about Mycoplasma genitalium treatment failure is that the CDC would like for you to submit all of your cases of this to their registry. They're actively tracking this and publishing about kind of treatment outcomes for these folks. You'll find a link to this in the CDC STI 2021 guidelines online in the Mycoplasma genitalium section, and I really encourage you all to submit some of that data as we're trying to learn the best thing to do for our patients in this scenario. All right, and I did promise to talk just a little bit about MGen in pregnancy. This comes up really often and actually drives a ton of consults to the STD Clinical Consultation Network. And so the data around MGen in pregnancy, like so much else about MGen, aren't really so clear-cut. The best we have is this 2022 meta-analysis that looked at the risk of adverse pregnancy and perinatal outcomes. They did find that there was an odds ratio of about 2 for MGen with preterm birth. Though there were a couple odd things about this. It was weirdly a little bit higher odds ratio for that outcome than with things like gonorrhea, chlamydia, trichomonas that we often think about as having these adverse pregnancy outcomes. And so the authors noted that that was a bit strange compared to this relatively sort of lower virulence pathogen. And also a lot of those studies kind of weren't able to look at co-founding. They didn't adjust for other variables besides some things like age that might also be associated with preterm birth. So we'll put preterm birth in this sort of MGen may be kind of a causal agent there, though the proof really isn't yet positive. For other outcomes like spontaneous abortion, they found that the MGen odds ratio was 1, so no evidence of association there. And for things like premature rupture of membranes, low birth weight, perinatal death, there was just too minimal data to draw any conclusion. New studies around these outcomes is coming out, but it's just extremely difficult to study in an organism that's also kind of a commensal pathogen and where there can be a lot of confounders. Authors here concluded there's insufficient evidence to recommend screening for MGen in asymptomatic pregnant patients because we just don't know that 1, the bacteria actually causes any of these outcomes, or 2, that treatment actually avoids them. And so if there's kind of one point about MGen that I want you all to come away with today, since you have a pretty good familiarity, it's that actually we should not be screening our asymptomatic pregnant patients for MGen. We know that it leads to a lot of probably unnecessary antibiotic use, and that also the usual treatment options for pregnant patients are not recommended for treatment in pregnancy. So both moxifloxacin and doxycycline, not really recommended. And so for your patients who do test positive for MGen, whether in the instance of symptoms from your clinic, or maybe they got tested elsewhere and came back positive despite not having any symptoms, there are a couple options. One is that it's really reasonable to defer therapy if they're completely asymptomatic. For patients with symptoms, we're really limited to azithromycin, and the regimen kind of looks similar to the old MGen treatment regimens with a 4-day course of relatively high dose. I often recommend that if you can, getting that macrolide susceptibility before just kind of giving azithromycin to folks. But doing that is kind of based on your access to that testing. All right. And so even though, like I said, I really don't recommend screening pregnant folks for MGen, especially if they're asymptomatic, we still do see a lot of these results coming back. And the big driver of this is probably the advent of these multiplex PCRs getting used for routine prenatal screening rather than a dedicated just gonorrhea and chlamydia test. So providers are trying to screen their patients for gonorrhea and chlamydia, but they end up getting all these other test results. And for that reason, I actually really recommend, if your practice uses these panels, being very selective about where they're employed, and trying not to be testing asymptomatic folks for any of these molecules. Ooh, double frown face. All right. So a couple take homes for MGen. It's a relatively common inhabitant of the male and female GU tract. The clinical syndromes that we encounter include urethritis in males, possibly but less likely proctitis, and in females, cervicitis and PID. The data really aren't there for demonstrating causality for preterm birth, spontaneous abortion, or perinatal death. MGen, as a really simple bacteria, actually carries intrinsic resistance to a lot of antibiotics. And of the antibiotics that we do have available, we know that macrolide resistance has unfortunately become prevalent, and fluoroquinoline resistance is on the rise. Treatment right now relies on sequential therapy with doxycycline to lower that bacterial burden, followed by moxifloxacin for cure, unless you have resistance testing available to demonstrate macrolide susceptibility, in which case you can use azithromycin. Options for treatment failure in the US include minocycline plus minus metronidazole, and also potentially kind of looking for macrolide susceptibility in that rare instance of a quinoline resistant but macrolide susceptible isolate. Options for treatment of pregnant patients are really limited. And in that setting, there's just no indication for screening pregnant patients in the absence of symptoms. And then, by request, I just wanted to add one little side note here. And we said we'd be talking about some of these other organisms in that molecules category. So the names you might be familiar with here are Mycoplasma hominis, Ureaplasma ureolyticum, and Ureaplasma parvum. In this case, there's actually no clear causal association of these with cervicitis, and so testing is not recommended. And thinking about non-gonococcal urethritis, at present, testing for those organisms is also not recommended by sort of the CDC STI guidelines or any of the other kind of larger STI guidelines. We just don't have any good evidence that these are actually pathogenic. And we know that a significant proportion of the population, like with MGen, but possibly more so, actually just carry these bacteria as part of their normal genital flora. And so there's just no role for screening for these in any population. You might read some things about ureaplasma, specifically Ureaplasma ureolyticum, as a possible pathogen, and the data on that are pretty mixed. In general, I recommend, especially if you're kind of unsure, reaching out to us at the Clinical Consultation Network if you're considering doing this kind of testing. All right. So I see that there are a couple of questions, and I'd love to make a little time.
Yes, so the first question here, in the vignette, I'm assuming you could just follow the doxycycline that the patient had already taken with moxifloxacin, correct? If there's a time frame between last dose of doxy and when moxy could be used. So this is referring to slide 24.
Yeah, I'm so glad you asked. We get this question every single STI intensive, I think. And unfortunately, there isn't a whole lot of data out there to guide us. None of the studies kind of looked at what might be a permissible gap between the doxy and the moxy. You're right in that the kind of ideal scenario is that you get the MGen testing back before that patient has kind of finished their doxycycline course, and then treat accordingly. If they don't, I think, something like 1 day, 2 days is probably fine. We know that doxycycline is not there as a curative therapy. And so ideally the, bacterial colony counts haven't recovered by then. But more than that, I probably would just go back to the doxycycline and do another week before moving on to your second agent.
Great. Do we do a test of cure for MGen, and if so, when?
Yeah, so in general, if you have a symptomatic patient who's tested positive for MGen, whose symptoms resolve after getting one of the recommended treatment regimens, then no, we do not do a test of cure at that point. For folks who do have some persistent symptoms, you might want to do a test of cure. In that point, it's actually, or in that case, it's really important to wait for a while after they've finished their course of treatment. So we tend to recommend to folks that they wait for about 3 weeks after finishing treatment before retesting for MGen. And the idea there is just that these gnats are really sensitive at picking up genetic material from bacteria, be they dead or alive. And so giving a chance for all of the kind of remnant bacteria or genetic material to be kind of washed out and avoiding a false positive test in that instance.
Would you do first-line testing in patients who have had MGen in the past, or still only at second line in gonorrhea, chlamydia, negative with symptoms continuing during or after presumptive treatment?
Yeah. I don't think that I would do MGen as first-line testing in someone just because they had a prior history of MGen necessarily. But there have been some places, some clinics that have looked at incorporating MGen testing as first-line for some populations, like MSM with non-gonococcal urethritis, or just MSM with symptomatic urethritis altogether. Just because, like we said, we know that there's actually a relatively high proportion of MGen as a causal agent in those scenarios. At the moment here, our practice is to typically reserve that as kind of the second round of workup.
And what do you do for partners?
Yeah. Right now, there's no clear evidence to suggest that MGen sort of partner therapy reduces the rate of somebody then going on to develop kind of recurrent MGen. You know, you're a patient who you're treating for MGen having a recurrence of symptomatic disease. We know that those rates of partner concordance are pretty high, and so partner therapy sort of makes sense in that context. We don't routinely recommend this. The CDC guidelines, I think, call this reasonable. And so for some folks who are having symptomatic disease, and definitely for folks who might have kind of a recurrence of disease and have a long-term partner where kind of treating that one person might significantly decrease their exposure, that might be a scenario where you consider it.
Great. It doesn't look like we have any other questions in the Q&A right now, but as questions come up, please drop them in there and we can address them at the end. And Jessica just put in the MGen FAQ document that's on her website. The link is there and it can take you directly to the resource that Dr. McLean has developed.
Amazing. So yeah, we got a ton of questions about this. Always happy to hear more. And I think collectively, we're all continuing to learn a little bit about MGen. All right, let's move on to something else though. So for our next case, we're going to be working with Jasmine. She's a 29-year-old woman who's coming in for an urgent visit, and she's reporting painful genital lesions for 5 days. She had a little bit of a fever that first day that she had the lesions, but that kind of went away on its own. She also had a bit of dysuria, which is improving. She doesn't report any vaginal discharge or pelvic pain, and she has also never had anything similar in the past. No new exposures to things like cleaning products, detergents. She does have one new male sex partner from the last 6 months. In terms of practices, she reports having oral sex, both giving and receiving, as well as vaginal sex. And she and this partner stopped using condoms about 4 months ago after a negative STI screening. She has not seen any similar genital lesions on her partner. When you go to examine her, you find many small erythematous erosions on the labia majora and minora, as well as the surrounding skin, and a few of which have started to crust. She also has some bilateral, tender inguinal lymphadenopathy. And so I think that the diagnosis here is not going to be a particular mystery to anyone. You can see kind of an example here of these erosions on the labia majora. But just to keep things a little more interactive, what kind of workup would you send for Jasmine at this point? Let's work with whatever we've got here. Okay, so, I see a number of folks have really leaned in hard to the multiplex PCR panel with all of the STIs. And, multiplex testing here actually might have a role. I don't know of a panel yet that tests for all STIs or that would be reasonable here, but we can touch a little bit on some of the multiplex things that are available as we go. The majority answer was the HSV1, HSV2 lesion PCR. And then some folks are including more comprehensive testing with things like an RPR, urine gonorrhea, chlamydia, NAT. I see small numbers of folks who have opted for some HSV antibodies as well as an HSV2 only lesion PCR. So I'll definitely want to talk about that. There we go. But before we do, let's go into some of the differential for genital ulcer disease. And so leading the list here is HSV in terms of frequency. There are some distinguishing features that I think you're all probably familiar with, a history of prior outbreaks. And it's also worth noting that systemic symptoms are pretty rare in non-primary infection. So most of the recurrent outbreaks really don't have some of that like fever and malaise that we see with some of this kind of initial infection. Primary syphilis we talked about yesterday. Of course, that ulcer is classically painless, but we also covered how rectal ulcers can often be painful. Mpox, which I believe you're going to be hearing about from my colleague, Dr. Zucker, is another good differential here. Systemic symptoms are almost always present at some point during the course for most folks with an initial infection. And the lesions can often look a little bit different, even though they're variable. The papular stage lesions do have that kind of classic umbilicated look, if you're able to catch those. LGV as another cause of genital ulcers that's worth your consideration. That ulcer is also classically painless and tends to be resolved by the time people present with other aspects of LGV. The inguinal lymphadenopathy is often really pronounced in men, and proctocolitis is the other kind of major consideration for rectal infection rather than sort of the genital ulcers. Chancroid and granuloma inguinale we won't talk about too much. They're both rare in the USA, but definitely worth thinking about, especially for patients with a history of travel to someplace that those are more endemic. And then a couple of other things that you might want to consider. Rashes that tend to be more generalized that can turn up in the genital or anogenital areas. Things like VZV, shingles cropping up in that dermatomal distribution, but isolated anogenital involvement is pretty uncommon. Molluscum contagiosum is also a potential differential here. Unlike some of these others, it tends to have a very classic look, and you tend to have these kind of painless raised lesions that don't really look like kind of some of the other things that we have listed here. All right, so for Jasmine, the answer we were looking for here was that HSV1, HSV2 lesion PCR that most everyone picked. And then in yellow, some of the comprehensive STI testing that would be great to send for any patients. All right, so in terms of Jasmine's results, you actually get back an HSV1 PCR that's positive, negative for the HSV2, HIV, RPR, and 3-site gonorrhea chlamydia all negative. So let's talk a little bit about HSV virology and epidemiology. We know that transmission is via direct contact with lesions, saliva, or anogenital secretions. We know that the primary infection is associated with a higher incidence of systemic symptoms as well as kind of higher severity of those local symptoms. After primary infection, HSV goes on to cause latency in sensory nerves that are then followed by those episodes of reactivation that we're all familiar with as outbreaks. Interestingly, we know that HSV1 reactivates more efficiently from trigeminal ganglia and that HSV2 reactivates more efficiently from the sacral dorsal root ganglia. And that's probably, or at least maybe, part of the reason why they've classically been associated with cold sores for HSV1 and genital herpes for HSV2. But in reality, either HSV can actually cause genital herpes. And in fact, rates of HSV1 genital herpes have been on the rise for some time now. There are some differences in kind of the clinical course of both of these. Recurrence and asymptomatic shedding are actually a lot more common with HSV2. HSV is actually really common. From sort of the last large sero study in 2015 to 2016, about 12% of US adults aged 14 to 49 were positive for HSV2, and almost half were positive for HSV1. Rates of clinical genital herpes, though, are a good bit lower. And so from more recent data from 2019 to 2021, it's somewhere around 250 per 100,000 person years. And while that's not so directly comparable to some of those percentages from the sero studies, you can kind of get a sense that there are a lot of folks who might be seropositive who aren't having clinical genital herpes, which is really important when we go to talk about some of our testing strategies. So, talking about diagnosis, knowing that a high population of people have those detectable antibodies but not symptoms is really what drives this recommendation for diagnosis centering on PCR. And so the HSV1 and HSV2 PCRs that we have are really sensitive, they're really specific, they can distinguish the two HSV types, and this is the preferred test. Viral culture is available in a lot of places, but actually has really low sensitivity, especially for recurrent lesions or healing lesions where the quantity of virus or viable virus might be really low. Its main utility is that it's the only way to detect acyclovir-resistant HSV, and so that might be a consideration in someone who's had a lot of exposure to acyclovir in their past and is still developing outbreaks. All right. For HSV serologic testing, the CDC guidelines break things down a little bit into some scenarios where you might find it useful, kind of marginally useful, or not useful. In that useful category are things like recurrent or atypical genital symptoms with a negative HSV PCR or culture result, things like the clinical diagnosis of genital herpes that a patient has maybe gotten somewhere, but has never gotten any lab confirmation. Occasionally, folks who have a kind of suspected recent acquisition episode about 12 weeks later to confirm that that was the actual cause. And also sometimes if a patient's partner has genital herpes and they want some additional information on their risk of being subsequently infected. You can imagine that if their patient or if the partner has genital HSV2 and your partner who maybe has never had symptoms is already seropositive, then kind of a new transmission event is really unlikely in that case. I really find that the only time I ever think about sending this is in somebody who has had this clinical diagnosis of genital herpes and their symptom history maybe isn't so consistent. And we're trying to kind of lock down what's going on. Occasionally, something like a positive HSV2 specifically can be helpful there. Otherwise, there are a lot of caveats for serologic testing for HSV, and I typically don't recommend it. These categories where CDC says might be useful of people at high risk for infection, like folks showing up for STI evaluation or people with HIV, I really feel like it's very hard to know what to do with a positive result in most scenarios. And a positive HSV2 serologic test in somebody who hasn't had a diagnosis of genital herpes can be really distressing. And so I often really kind of try to steer people away from this. And we know that HSV2 antibody testing is really just not useful at all for screening in the general population. So, for Jasmine, our patient, what treatment should we offer her? Is it a week of valacyclovir twice daily, the Valtrex 1 gram for 5 days, a 1-day high-dose valacyclovir course? Does she need IV acyclovir? Does she need an indefinite course of daily valacyclovir? Or should we see about curing this once and for all? Just get those spinal dorsal nerve root ganglia out and maybe get her some new ones. All right. Let's see what we got. Okay, overwhelmingly, people have chosen the 7 to 10 day 1 gram Valtrex twice daily, with a smaller but significant number of people going for the 5-day Valtrex course, and a few people suggesting that maybe she could use kind of an indefinite therapy with an antiviral agent. No one is pioneering any new surgeries for the dorsal nerve root ganglia, but if anyone does have any leads on that, please, I'd like to know. But for Jasmine, this is really a first episode of genital herpes, and everyone with a first episode of genital herpes should get antiviral therapy. There are a few options here. These are all closely related drugs that essentially work the same day, and their main difference are in the dosing schedules and possibly the availability at your local pharmacy. The valacyclovir 1 gram twice daily for 7 to 10 days is kind of my default. Note here that treatment can be extended past that 10 days if healing is really still incomplete at that time. And then treatment for recurrences is, we have a few more options, and there are a couple of different strategies. So one is treating episodically, or what's called intermittent therapy. The goal here is to ameliorate or shorten the duration of the outbreak and of symptoms. And this might be especially appropriate in people who have less frequent recurrences, including folks who have HSV-1 genital herpes, where we know that recurrence rates go down pretty quickly after that first outbreak, and that genital shedding actually decreases as well. This is also, of course, a really reasonable option for people with HSV-2 genital herpes who have infrequent outbreaks or who just don't want to take a daily medication. For suppressive therapy, this is a great option in people who want to reduce the frequency of recurrences. And this comes up a lot more in folks with HSV-2 genital herpes, since we know that almost everybody who has a symptomatic first episode goes on to develop some of those recurrences. And this suppressive therapy can decrease that recurrence rate by up to 70 to 80% in people with frequent episodes. There might also be some benefits in preventing transmission using suppressive antivirals, and we'll touch on that in just a moment. There are a plethora of options, all still relying on the same agents for both suppressive and intermittent therapy. I really recommend just kind of finding one that you can remember and that you know is widely available. I tend to use valacyclovir for this purpose. The dosing is a little bit easier. For suppressive therapy, kind of the main option that's most convenient is 1 gram once a day. And then for intermittent therapy, 1 gram once a day for 5 days. But you can choose any of these that are kind of widely available and that your patients feel comfortable keeping up with in terms of some of these dosing schedules. Of note, the dose and duration are increased for immunosuppressed folks, including folks with HIV. Just a side note when you're going to do this prescribing. All right, so for Jasmine, she has a first outbreak. The Valtrex 1 gram twice daily for 7 to 10 days is an appropriate option here. That second option would be appropriate for a recurrence. The Valtrex for 1 day for a cold sore, the IV acyclovir for HSV encephalitis, a really scary phenomenon that I hope we're not encountering in our clinics, and the indefinite valacyclovir for suppression. All right, and so speaking of suppression, let's talk about preventing HSV transmission. There is evidence to show that daily valacyclovir lowers the risk of HSV transmission, specifically from HSV or HIV negative people with symptomatic genital herpes, on the order of about 50%. It's unknown if that's actually true for folks without a history of symptoms. So in those cases where you have a kind of incidental HSV2 antibody that's already been done, it's not as clear how you can counsel these folks. And we know that it doesn't seem to be effective for people with HIV who aren't on antiretrovirals. So HSV or daily Valtrex for preventing transmission really kind of works best in folks who are HIV negative or are on ART and who have a history of symptomatic genital herpes. Condoms also decrease but don't eliminate the risk for HSV2 transmission. The sort of numbers there are a little less clear. And male medical circumcision has also been shown to reduce transmission. A couple important notes about times where it's really critical to think about HSV transmission are during pregnancy. So for patients who are pregnant and whose partner have a history of orolabial genital herpes, it's important for them to avoid genital or oral sex in the 3rd trimester especially, and for them to be monitored closely peri-delivery. Pregnant patients who themselves have a history of genital herpes should be offered suppression starting at 36 weeks to reduce the risk of recurrence during delivery, C-section rates, and asymptomatic shedding during delivery. All right, HSV patient counseling. And this is actually really important and something that I kind of didn't expect as I started doing more sexual health. But patients really have a lot of stigma attached to genital herpes especially, and so counseling them, I think, is really critical and something that's really important for us to be able to offer to our patients. And so patients with a history of genital herpes, and specifically HSV2 genital herpes, are recommended to disclose to prospective sex partners. Transmission is more likely when lesions are active, but can occur during asymptomatic periods of viral shedding. And serology, when people have that result, can't determine whether someone is infected orally, genitally, or both. We know that HSV2 transmission, like we said, can be reduced but not eliminated by suppressive medication and male condom use. But suppression is not proven to reduce the risk of transmission of HSV1, if that's a main concern. We also know that people with HSV2 are at increased risk of acquiring HIV when they've been exposed via sexual contact. There's actually a lot more HSV patient counseling points that I think are important to make. At the end of this presentation, there's a link to some patient handout materials from the American Sexual Health Association, ASHA, which is what I often use in clinical practice because I think it's really helpful for folks to have something they can take home with them. All right, a few takeaway points. So when possible, HSV diagnosis should be confirmed with PCR testing from an active lesion. Serology can help support a diagnosis when you don't have active lesions to test, but it's not conclusive and really isn't recommended for things like screening or for folks who have something other than kind of an unclear clinical history where you're trying to get some evidence to support an HSV clinical diagnosis. All patients with a first episode of HSV should get antiviral treatment, and then subsequent outbreaks can be treated with either episodic or suppressive therapy. Suppressive therapy really being preferred for those with frequent outbreaks. HSV1 is actually an increasingly common cause of genital herpes, and so should be something you're including in your testing. But it's associated with fewer outbreaks and less viral shedding and kind of an overall less severe clinical picture. HSV2 causes those more frequent outbreaks and really increases the risk of HIV transmission. All right. These are those resources from ASHA that I talked about. And then the CDC STI 2021 guidelines actually do a great job of kind of bullet pointing out a bunch of different patient counseling points as well. Right. Before we move on to our last little section in the time that we have left, any questions that I can answer about herpes?
Yes, we have one question here. I am under the impression that there are multiple genotypes of HSV that can cause subsequent acute outbreaks in people who are already seropositive with a different strain, even within HSV1 or HSV2 themselves. To clarify, this question is related to serology testing for HSV to show both partners are positive and cannot spread disease to each other.
Yeah, so I am not familiar with kind of a vulnerability to different strains of HSV1 or HSV2. What I think the CDC guidance around using serology in that context might be is for sort of long-term partners where one partner might have already been exposed to the HSV sort of from their partner. And so I guess presumably the same strain, if that difference is important. And in that context, you know, being able to say that that person's already been exposed. I don't know if that would globally apply to sort of anybody with any HSV2 and anybody else with potentially different HSV2, but I'll look into that.
What do you offer to patients who have a severe and painful initial genital HSV outbreak, particularly for painful lesions?
Yeah, and so besides antiviral therapy, which of course can only shorten the duration of symptoms, we know that symptom control is also critical and kind of supportive care. Over the counter, just regular oral analgesics can be one thing, Tylenol or NSAIDs. Protecting the kind of area that we're talking about to prevent bacterial superinfection can also be really important, and assessing for bacterial superinfection in folks who kind of have outbreaks that then get worse after the initial ulcerations or healing. And then sometimes topical anesthetics for folks. I've used those a little bit less in my practice, but seen them used, things like topical lidocaine.
Great. And last question here. For first HSV outbreak treatment, does it matter how many days into the episode you see them and the state of the lesions?
Yeah, I gather you're asking, if you see somebody really late in the outbreak, is there any point in giving them antivirals at that time? I think that the general approach is to say yes if they are still symptomatic, regardless of if the lesions are crusted, et cetera. The risk benefit probably still favors giving antivirals at that point. Obviously, if you see them and the episode is completely over, then there's probably not much point in doing antivirals at that time.
Great. We don't have any other questions right now, so you may proceed. For participants, if you do have additional lingering questions, please drop them in the Q&A and we'll address them at the end.
All right. So for our last case, we may be a little bit time limited here, but we'll be dealing with Josh. Josh was 54, coming with 3 days of testicular pain and swelling that came on over the course of just a day without any preceding trauma. He reports some associated dysuria and no urethral discharge. And does have some chronic medical problems, including hypertension, type 2 diabetes on metformin and empagliflozin. He also takes PrEP, not allergic to anything that he's aware of. In terms of sexual history, his sex partners are men. He practices insertive and receptive anal sex, gives and receives oral sex. He had 2 partners in the last 6 months, and uses condoms with new partners, but has a primary condom with whom he does not use condoms. On exam, you find some right-sided scrotal erythema and swelling, and the right testicle in its normal vertical position. It's exquisitely tender, and there's some palpable localized swelling along the posterior aspect and in the spermatic cord. The chromasteric reflex is intact. And so I don't need anybody to necessarily chime in, but just to think for a minute about some possible differential diagnoses here. Okay. And because the point of this presentation is not to puzzle you with mysteries, I will tell you that this is epididymoorchitis, and I find it helpful to look at an anatomical diagram here just to make the point that to have an infection reach the epididymis and the testis, it actually has to travel a pretty good ways, either from the external urethral opening back through the entire urethra and then back through the vas deferens to the epididymis itself, or alternatively from the urinary tract, say from the bladder, along then that same route. So this is actually something that's relatively uncommon, perhaps partly because there has to be a pretty significant bacterial sort of exposure and the opportunity for it to really travel kind of in retrograde along this whole pathway. The presentation is pretty much exactly as we've described our patient. There's unilateral testicular pain and swelling. The onset's typically acute, and it can occasionally be chronic, but it's not sudden. It's not something that happens over the course of kind of an instant. Concurrent dysuria is typical. On the exam, often sort of swelling and tenderness of the epididymis and testis is present with some palpable kind of scrotal edema, rather more than hydrocele there, sorry about that. And then spermatic cord, of course, is also typically tender. Also, the testicle is in its normal position in these cases, so not horizontal, and that comes into play when we think about our differential. So when we're thinking about acute epididymitis, we're thinking about a couple different categories of things. There's sort of the STI organisms and then the enteric pathogens. Among the STI, we have our classic gonorrhea, chlamydia, and NGen. And among the enterics, we have things like E. coli and other sort of gut/UTI type organisms. Classically, the STIs have been associated with sort of younger patients who are sexually active, and the enteric pathogens maybe for older folks who might have urinary obstruction or instrumentation, but are also associated with insertive anal sex. We'll take a look at such evidence as there is around this to support or kind of maybe not support some of those associations. There's also a differential for chronic epididymoorchitis, where from an infectious standpoint, TB globally is actually the most common thing. But there are some other things like post-infectious pain, drug-induced epididymoorchitis, or inflammatory syndromes. The main differential that I think we want to be able to consider and rule out as testicular torsion, which has that hyperacute sudden onset, is associated with sort of the testis in a horizontal position and that absence of a chromasteric reflex. That would be the main thing that would kind of change your immediate management, and those folks need to go to the ED. All right, so diagnostics that we would want to send for this patient. I would suggest something pretty simple, and it's just a urine gonorrhea chlamydia, a UA with a microscopy and reflex culture, and then in a case of Jeremy specifically, comprehensive STI testing, just given the history. And then what treatment should we start for Josh? And just because we don't have a ton of time, let's go ahead and call it. And I see that most folks are suggesting ceftriaxone and doxycycline with kind of a smattering of other answers. So let's actually get into that just a little bit. Sorry, y'all. There we go. Okay, so moving right into some of the recommended treatments here. The ceftriaxone and doxycycline regimen that a lot of you all picked is appropriate for folks who are sexually active and have kind of a low risk for enteric pathogens. And in the STI guidelines, they kind of characterize this as no history of insertive anal sex, no history or suspicion of urinary tract obstruction or instrumentation. For our patient, we know that he's having insertive anal sex. We also know that he has some other medical complications that might predispose him to a UTI, things like diabetes and the use of an SGLT2 inhibitor. And so in his case, he's at risk both for STI type pathogens as well as those enteric flora. And in those instances, CDC guidelines actually recommend ceftriaxone plus levofloxacin. This gives pretty decent coverage still for the chlamydia that you might be using that doxycycline for previously, as well as the things like E. coli and other gut pathogens. A regimen of levofloxacin alone is the recommendation for patients who might be most at risk for enteric pathogens and really aren't sexually active. Bactrim is a reasonable alternative there. And a couple of the other options here with ceftriaxone plus doxy plus levaquin really kind of duplicates therapy for chlamydia and is unnecessary. And then in terms of waiting for results of testing, epididymoeorchitis isn't the same kind of emergency as abortion, but it really is recommended to give empiric treatment while waiting for results. All right, so Josh's test results come back, and the urine culture does show Proteus vulgaris, which is pan-susceptible, and a negative gonorrhea and chlamydia and negative other STI testing. So for your patients with epididymoeorchitis, after you get the results back to kind of demonstrate a cause, you want to tailor antibiotics to either those gnats or the urine culture, offer them symptomatic relief with scrotal elevation and NSAIDs, and then counsel them that it might be a while until the discomfort actually resolves despite curing the infection. So it can be up to weeks. For people who have negative results and persistent symptoms, like in some of the other syndromes we discussed, going looking for those other causes would be a good next step. MGen testing would be an option here. And then if that's negative, thinking about having them see urology if they haven't already done. And so for this talk, because the epididymitis and orchitis guidelines are actually really straightforward, I wanted to kind of walk with you all through some of the evidence that's out there in epididymitis and what's new. The answer in terms of what's new is actually not a lot. So this is a systemic review from articles published between 2006 and 2017. And they actually only found one study that met their inclusion criteria. It was a retrospective review from just a couple of STI clinics in Canada about epididymitis due to gonorrhea and chlamydia. They noted that kind of the chlamydia was the most prevalent organism in their patient population, with a few people having co-infection, and noted a couple of episodes of gonorrhea treatment failure. But really didn't have a lot to kind of add otherwise to the discussion about epididymitis and orchitis. This is a slightly older article where they tried to get a little bit more into the specific distribution of kind of etiology of epididymoeorchitis. And so they looked at 137 patients who had acute epididymitis. I'm sorry, that's 237 patients with acute epidermolysitis, 150 of which hadn't taken any antibiotics, 87 of whom had, and then did a really intensive investigation where they did cultures, STI testing, and then if culture negative, actually did molecular analysis with 16S rDNA and multiplex viral PCRs. This population was a little bit older, the median age in the 50s, but actually had a pretty significant proportion of folks who are sexually active in both the antibiotic naive and pre-treated group. So what they actually found doesn't entirely support some of those previous assertions that young folks primarily have STIs, whereas older folks primarily have enteric pathogens, though there are some trends in that direction. So you can see kind of on this top graph here, the red represents STDs, the green represents enterics, and while there is absolutely kind of a shift from predominance of one to the other over time, enteric pathogens are still a pretty significant proportion in this younger age group, and the STI proportion really doesn't go away as you go down the line. This bottom graph is for folks who were still having symptoms who've been kind of pre-treated, and you can see the STIs are a little bit higher proportion there. All right, so just a couple of take-home points about epididymitis and epididymoorchitis. So the onset's acute, but not sudden. It tends to be unilateral and is often, but not always, associated with dysuria. Differentials include things like gonorrhea, chlamydia, and MGen, as well as enteric pathogens like E. coli, Klebsiella, Proteus, etc. There is some evidence to suggest that other organisms can play a role, like H. flu or enteroviruses, but often not things that we're readily able to test for. Testing that we tend to do in clinic really relies on some familiar things like urine, gonorrhea, and chlamydia, plus minus an MGen nat, as well as UA with microscopy and culture. For treatment, it's just important that you want to do ceftriaxone and then add levofloxacin instead of doxycycline if your patient might be at risk of enteric pathogens in addition to STIs. And then supportive care is also really important, with NSAIDs, scrotal elevation, and reminding your patients that unfortunately those symptoms might kind of hang around for a while despite kind of successful treatment. All right. And I think that'll make it a wrap with just a few minutes left over. Thank you for bearing with me. Happy to take any other questions.
Yes, we have a few questions here. Especially because of the stigma related to discussing this HSV with patients, are you able to share language you use around revealing HSV status to future partners?
Yeah, and so I do want to make just one more plug for these OSHA handouts, which do include some language around that. It isn't quite maybe the script that you are looking for, but I think has a lot of phrasing that folks can kind of recycle. And the way they kind of approach things are, that HSV is an irritant, is a bothersome kind of chronic condition, but is not sort of otherwise dangerous in most of the ways that we might think about some of these other things. It doesn't have some of the outcomes like syphilis, etc. And for most folks is entirely manageable with medications. While I don't have a specific script myself for kind of how I tell each patient to approach their partner, and I kind of ask them how they've thought about it or how they would consider approaching, and then try to build on that. I think there are some good examples in there.
Great. For a patient with a history of HSV-2 who has been maintained on suppressive antiviral therapy and has not experienced any recurrent outbreaks, what is the recommended protocol for reassessing the need for continued suppressive treatment? Specifically, is a monitored trial off antiviral therapy advised to evaluate whether ongoing suppressive management is still indicated?
Yeah, absolutely. And remember that suppression is kind of a shared decision choice with that patient. They don't have to continue taking it for any sort of medical reason. It's really there for primarily symptom control, with the caveat, of course, that sometimes there's a transmission limiting component as well. So from the symptom control perspective, it's really reasonable to kind of revisit that after, say, a year of infrequent or no outbreaks, and ask if that person still feels like they want to continue taking this. And if not, doing kind of like you suggested, a trial off of antibiotics to see what kind of recurrences happen after that. Obviously, the conversation where you might be using suppression to prevent transmission can be a little bit more nuanced, knowing that transmission might not be, or that suppression might not be 100% effective for that purpose, and that's probably a conversation that involves that patient's partner as well.
And just want to plug a resource here. Folks can look into a patient-led group called Something Positive for Positive People. This is for HSV.
Oh, cool. Okay. Yeah, I'd love to look into that.
And it looks like we have one final question here. Can you talk more about multiplex PCR panels for all STIs and when they should and shouldn't be used?
So I'm not sure. I don't think there is a multiplex PCR panel for all STIs yet in existence. There is one particular instance that we sometimes are able to use a multiplex PCR that's, I think, available from Europe, if I'm not mistaken, and that is for genital ulcers. When you're thinking about things that might include HSV, when you're thinking about potentially Mpox, when you're thinking about syphilis, and some of these less common things like chancroid, genital ulcers, I think, are probably going to be the ideal target there. For other things, it's going to be a lot more challenging.
I think those are all of our questions, so I'm going to wrap up. Thank you so much, Dr. McLean, for your excellent presentation today. I'm just going to do just some final reminders. So I want to thank Jacob McLean and all of our other speakers today, as well as our participants for their thought-provoking questions and for joining us today. Please join us tomorrow morning. You can click the same Zoom link and we'll meet tomorrow at 8:45 a.m. Additionally, if anyone who has joined us today without registering, please let us know. You can email us or send us a chat. That way, we can get you registered. And just want to remind everyone that CE is only available if you attend at all 3 days and you are registered for this course. Lastly, slides will be shared at the end of the program, so you'll get all of this information as well as the resources that we shared today during presentations. Thank you everyone so much. Looking forward to seeing you tomorrow. Oh, and one final thing from Dr. McLean.
Not the detraction from Cindy's beautiful closing comments, but I wanted to make sure I didn't leave out. Some of you might have been thinking of multiplex PCRs for things like vaginitis, which is a really common offering from a lot of the commercial labs. And so that actually would be a really reasonable time to do things that look for, gonorrhea, chlamydia, trichomonas, sometimes candida, sometimes BV. Those are also really reasonable things. The only thing I would suggest is that if you are using those in your practice, that you really think about not having mycoplasma genitalium as part of that kind of default workup, and that you reserve that as kind of a dedicated test. Okay, that's it. Thanks, y'all. Have a good one.
Thanks, everyone. Take care and see you tomorrow.